I'm Jerry Harrison. Y'all know that from yesterday. I'm a family physician from Haleville, Alabama, and I'm on the Board of Medical Examiners. Federal and state regulations, this is actually an optional slide, but we're going to go over it. Code of Federal Regulations, Title 21, Section 1306, is the governing the issuance and filing of prescriptions pursuant to 309 of Act 21. But that's where it's in the CFR, Section 21. If you ever want to go look up the minutia of the details of the federal laws regarding prescribing. In the state, Buddy went over the pertinent legislation there. There have been changes this year that will change somewhat, but they really shouldn't affect the physicians as much as the nurse practitioners, because y'all will be stepping into new territory. Clinicians and patients should regard initial treatment with opioids as a therapeutic trial. Consider there to be a relative contraindication to use of opioids when you're first starting them. You got to determine when you're using this trial whether or not that treatment is appropriate for this patient. An initial course of treatment with opioids for chronic pain should be viewed as a short-term therapeutic trial which can last from several weeks to several months. The decision to proceed should be based on consideration of the outcomes of this trial, including progress toward meeting your therapeutic goals that you set up with your plan of care, including in improving the pain severity and improving functional ability, the presence of any side effects or aberrant behavior. In patients who experience mild to moderate side effects, a longer trial can be used, but if they're having aberrant behavior, you need to consider going to a different treatment for these people. ERLA, opioid-induced respiratory depression. It's the chief hazard of using agonists, including these medications. If the people have risk factors, this increases their risk of having this. This is the cause of most deaths from opiates, is respiratory depression. If it's not immediately recognized and treated, it may lead to respiratory depression and death. If they're titrated up too quickly, if people have been on medications before and then for some reason have been to rehab, for example, and been off the medications, when they start back on those medications, that is when they are at risk. People who've never been on long-acting opioids and you start them on them, if you start them on too high a dose, if you titrate too quickly, then those are the people who are at risk. I can't tell you how many times I've heard about people who had been to rehab. They get out of rehab. The rehab didn't really take. They were just there in a holding pattern until they could get out and get drugs again. They get out, they get them some, they go back to the dose they were taking before they went into rehab, and they wake up dead. I mean, it just kills them. And another one of my sayings is the methadone that you take for pain today may kill you tonight. And we'll talk about that in a few minutes, because the methadone has a different pharmacokinetics for the respiratory depression and the pain relief. Again, we encourage, from the Board of Medical Examiners' point of view, that you try other ER long-acting opioids other than methadone. Methadone can bring you in a lot of patients, but it brings you in a lot of problems. Respiratory depression from opioids is manifest by decreased urge to breathe, shallow breathing, and chain stoking. And when you've seen somebody chain stoking, it's impressive. As I talked about yesterday, my lab tech from my office, I was giving him medication for a big kidney stone, and all of a sudden he passed the stone and he became apneic. And so we were just lucky that we were able to resuscitate him. You have to instruct your patients on what to do if something happens. and I reckon the reason I was selected for this speech is to tell you to call 911. And the reason for that is because 911 was started inhalable. So that's the reason they selected me for this. If people have an emergency, have a respiratory arrest, call 911. That's your federal government at work telling you how to do that. Opioid-induced respiratory depression is more likely to occur, as we mentioned, in elderly, cachectic, debilitated patients. It's contraindicated in patients who are already respiratory compromised. And if it's given concomitantly with other medications that depress respiration, or if it's given with other depressants such as alcohol. Remember that one. Yeah, flip to the right page. Okay, reduce risk. Proper dosing and titration are essential. Do not overestimate the dose when converting from one opiate to another, and we'll talk about that a little more in just a moment. Instruct patients to swallow these long-acting, extended-release whole. Okay, you know, when you got people that tell you, well, I'm just taking half of my OxyContin or I'm taking half of my MS-Contin, it's time to really have a discussion with your patient because they're taking a medication that's supposed to last a long time, and they have now altered the medication and it may kill them. What's the complication of taking a medication like that? When you crush it or something, they may die. Look for that one too. To reduce the risk of respiratory depression, proper dosing and titration is essential. When you're changing from one opioid to another, you always reduce, regardless of which equal dose table, equal analgesic table you use, you're always going to reduce a little bit because there's incomplete cross tolerance, and we'll talk about that in a moment. Okay, when you're initiating and titrating medicines, prescribers should be aware that dose and dose selection are critical when initiating a long-acting opioid therapy in naive or non-tolerant patients. Tolerance to the sedating and respiratory depressant effects is critical to safe use of some of these medications, to all of these medications. And certain doses are even more critical. Patients considered opioid tolerant are those who are taking at least the following for a week or longer. Okay? 60 milligrams of oral morphine a day. 25 micrograms of transdermal fentanyl per hour. 30 milligrams of oxycodone a day, 25 milligrams of oxymorphone a day, or an equivalent dose of another opioid. Now think about this for a moment. Fentanyl patch comes in a 12.5 microgram per hour. If they're using that for 3 months, according to this, they are not opioid tolerant. So there are certain medications that you are not supposed to use if the people are not opioid tolerant. Now, one of those medications is transdermal fentanyl. So even though you've been using the 12.5 microgram, according to the regulations designed by the federal government, you can't use transdermal fentanyl. So there are some internal inconsistencies in this. But what it really means is you can't go up on the fentanyl in a hurry, and if you're changing from another opioid to fentanyl at 25 micrograms, you have to have a reduction. And speaking of that, when you're changing from another opioid to transdermal fentanyl, you're very conservative on the fentanyl because of the risk of respiratory depression. So that is a one-way transition. You cannot turn that transition around and say, okay, somebody's taking 50 micrograms of fentanyl, and so we're going to look at this equal analgesic dose and give them that other dose. It doesn't work that way. Changing to fentanyl patch is a one-way street. Don't go the other way. In patients who are opioid naive, long-acting opioids should be started at the lowest dose and titrated slowly. That's to decrease the risk of opioid associated adverse events. Okay, you can base the dose on their previous treatment, But there are certain medications that the higher doses are only to be used in people who are opioid tolerant. And when you got these people on, don't skip doses. Incrementally increase your dose. As Dr. Smith said, start slow, go slow, and monitor your patients. Make sure they're not having side effects. If they say, I'm still hurting, and you just increased their medicine yesterday, and this is a long-acting medication, it may take several days for that increase to become steady state. Patients should be monitored closely for respiratory depression, especially in the first 24 to 72 hours of initiating therapy or increasing a dose. In general, this is all the time, you should individualize the dose for each patient. Older people, those with other comorbidities, may benefit from a more cautious approach. Prescribers should check the long-acting opioid package insert. There are many different equal analgesic dose tables, but specifically if you have questions, you go to the package insert for the one that you're changing to or the one that you're changing from, and use those, because that way it'll keep you out of trouble. Patients should be taking, this is what we just got through saying, 60 milligrams of oral morphine, 25 mics of fentanyl, we've just gone over this, 8 milligrams of hydromorphone. Now, hydromorphone is dilaudid, and that is a very potent medication. Fentanyl is very potent on a microgram per microgram basis, or 25 milligrams of oxymorphone, which is another potent medication. And then it says an equal analgesic dose. That's where you look at these doses if you're trying to see what they should be taking. Opioid rotation. There is some theoretical benefit from if somebody says, hey, this one's not working anymore, I want to increase dose, and you say, well, let's don't go to increased dose, let's go to a different medication for a while. But like the example from the previous slide, Peter that came in at 4:45 on Friday, the only thing that worked for him was oxycodone. Well, be careful when people tell you that the only thing that works for them is their drug of choice. Okay, so when somebody tells me, the only thing that works for me is this, that makes that medication an even greater relative contraindication for me to give it. I usually don't want to do that because they are invested in that medication. This is one strategy among many to address unsatisfactory outcomes following an opioid administration or dose escalation. This may or may not be the best approach to use, but it is one approach to use. Both the immediate and long-range goals of opioid rotation is to establish an opioid regimen that is more effective than the prior therapy, and also to keep the patient from developing an affinity for that particular medication. Effectiveness encompasses increased analgesic efficacy, decreased adverse events, and improved treatment-related outcomes. The theory behind this is incomplete cross-tolerance to the analgesic and non-analgesic effects of opioids. There is polymorphism at the mu receptor, and the mu receptor is the primary opioid receptor. And that's good and bad. It's good because people who have become tolerant to one may not be as tolerant to the other, but it also means that they can overdose when you change if there's more sensitivity to the respiratory depression in the new medication that you have selected. Clinicians have long exploited this incomplete cross-tolerance in opioid rotation, where highly tolerant patients are rotated to a different drug and they have more efficacy, more analgesic sensitivity, less side effects. The utility of this approach is based on the observation that the relative potencies of different mu opioid drugs to each other in highly tolerant patients is not the same as in opioid naive patients. They become accustomed to that medication, and it's like the mu receptor becomes accustomed, like a hand into a glove. The glove gets where it fits very well, and you don't feel like it's on there. So it means the medication, they become too accustomed to it, so we want to change to something else. When rotated, the patient shows far less tolerance to the second drug, permitting the rotation of analgesia. I've used this some. It is not a panacea, but it is something that we can use beneficially. The mechanism and action of pharmacology of opioids is complex. The mu-selective opioids bind to a large number of the mu receptor subtypes, the polymorphism in the mu receptors, with the various opioids produce subtly different effects. Sometimes this effect is more than subtle. While different opioids bind to all of the mu receptors and produce similar pharmacological effects, the changes can be significant. This may help explain some of the interpatient variability in the pharmacologic response to opioids and the incomplete cross-tolerance. The indications for switching in the existing opioid therapy is poor opioid responsiveness, poor analgesic efficacy, occurrence of intolerable side effects, patient desire to try a new formulation, adherence, problematic drug-drug interactions, financial or drug availability. You know, we had some of these medications that people were using and then all of a sudden they became unavailable. So we had to change regardless of what the patient wanted. Concern about drug abuse or diversion. You know, the only thing they need is oxycodone long-acting and oxycodone immediate release. That's what the guy in the previous illustration wanted. Change in the clinical status if they've developed malabsorption. If they have had an intervening injury, you may need to change their medication somewhat. And always look at the patient. You know, if a patient's got a particular disorder and something happens to change their situation, you may have to reevaluate that patient. Opioid rotation requires a calculation of an approximate equal analgesic dose. To effectively rotate from one opioid to another, the new opioid must be started at a dose that will cause neither toxicity or withdrawal and will be sufficiently efficacious so that pain is no worse than it was before the change. To implement opioid rotation, a prescriber must first calculate the approximate equal analgesic dose for the current opioid and the new opioid. Oftentimes that means going through the standard intermediate, which is like morphine 10 milligrams oral. And so if you don't have an equal analgesic table that's got both the medications you're considering, you convert it to morphine, and then you convert morphine to the new one. That has some inherent risk in it, so what do? The new medication you institute at a reduced dose of 25 to 75% reduction. We introduce the new medication at a reduced dose of 25 to 75%. Therefore, the selection of a starting dose must be informed by an estimate of the relative potency between the existing opioid and the new one. The relative potency, which may be defined as the ratio of opioid doses necessary to obtain roughly equivalent effects. Once initiated, the new opioid must be individualized to the patient through the process of dose titration and treatment adverse events. There are challenges to opioid rotation. As the federal government is wont to do, they have acronyms, and an equal analgesic dose table is an EDT. Part of being a government employee is the first 5 years is learning all the acronyms. There are many different versions of these equal analgesic dose tables. Many of them are put out by specialty societies. They're put out by various manufacturers. But the standard ones are the ones that are going to be in the PDR. Prescribers often consult these before opioid rotation, and we should always consult them. Even if we don't consult it in written form, it has to be something that we're aware of. You know, we know that oxycodone is 1.5 times more efficacious than morphine, so you do that dose calculation in your head. Investigators surveyed commercially available and educational materials for equal analgesic dose in package inserts, the PDR, teaching items provided by the pharmaceutical companies, and internet websites. The objective was to examine the variation. They found major variability in the root conversion ratios for commonly used opioids and in the recommended equivalence ratios for rotation between and among different opioids. Other researchers searched major online application stores for applications that convert opioids at equal analgesic doses. I have 2 apps on my iPhone that help me convert. They are different. They'll come up with different amounts. So that's the reason why when we convert, we cut down on the dosage of the new one. What's our ultimate goal? First, don't put them into withdrawal. Second, try not to make them hurt any worse. But if you're going to make an error on the low side, because you can always increase the dose, but it's hard to take medicine back out once you put it in there. And once they've quit breathing, it's hard to stop that side effect. So err on the low side and titrate up. You can titrate up beneficially over a few days. Therefore, there are multiple considerations that should be addressed before rotation and conversion to avoid errors in applying any EDT. Errors are best avoided by knowledge of the opioid pharmacology, awareness of the limits of the equal analgesic dosage, application of the guidelines, and tailoring the opioid to the individual patient. Going back to it once again, oral morphine 30 milligrams is equal to 10 milligrams of parenteral. Parenteral morphine is 3 times as potent as oral. Oxycodone, 20 milligrams of oral is 1.5 times as potent as oral morphine. They list not applicable here for parenteral. That's because it's not available commercially. You have to go to your local drug user shop and they'll show you how to grind up your oxycodone and make it parenteral. But for obvious purposes, they have not put that on here. Hydrocodone, once again, 20 milligrams. It says that it's 1.5 times as potent as oral morphine. That means this is saying that hydrocodone and oxycodone are equally efficacious. And through your experience, you probably know that most patients don't consider it that way. They consider oxycodone to be a little bit more efficacious or a little stronger on a milligram per milligram basis than oxycodone. I mean, oxycodone stronger than hydrocodone. For example, Percocet, in most people, they consider it to be stronger than Percocet 10 than a Lortab, Norco, or whatever 10. Hydrocodone 10. Hydromorphone. Oral hydromorphone is 4 to 7 times as potent as oral morphine. Notice that range there, 4 to 7 times. It is much more strong than oral morphine, but look at the parenteral. The parenteral hydromorphone, which is dilaudid, is 20 times as potent as oral morphine. It's a strong medication. Be careful with it. Fentanyl, orally, it says it's not applicable, but you got the lollipops, you got the sublingual, you got several different ways that fentanyl is given now. I encourage you, don't start with that. That's not an initial dose. That's a medication to use after the people are seriously opioid tolerant. But transdermal fentanyl is 80 times as potent as morphine based on studies converting morphine to fentanyl. Remember that the fentanyl conversion tables are one way because you're very conservative when you're changing to fentanyl. Prescribers have to realize and recognize the limitations of these dose tables. Proceed with caution. That's the main thing, is just be cautious when you're doing this. Limitations are from several aspects that we've talked about, the different sources they come from, the reasons the people have for doing these, where they were done by a manufacturer, were they done by the PDR, were they done as part of the package insert, has it been reviewed by the DEA, because some of these, are commercially available or educationally available. They have not been reviewed. Some of these dose tables are not reviewed by the DEA. Most studies include potency, largely included non-opioid tolerant populations in single or very short dose increments. So these tables have an inherent weakness. They're not made for the people that we are usually using these medications on, which are people who have been taking medications for a while. That emphasizes that these tables are starting points only. And when you transition, go lower than you expect and titrate slowly. Because they do not assess the influence of chronic opioid administration or the dose at the time of a change, they may not be directly applicable. Patients in these studies where they did these equal dose usually had no concurrent illnesses, and that's not typical of the patients that we're treating. They didn't have organ dysfunction. They didn't account for the difference of responses based on gender, ethnicity, age, or concomitant medication use. Studies did not always assess the direction of switching from one drug to the other. For several opioids, the potency varies depending on the direction of the switch. They also could not evaluate the formulations and drugs that have come into clinical use since these tables were concocted. The equal analgesic dose table remains a cornerstone of published guidelines for opioid rotation, but a review of the science and the clinical practices that have evolved around their use demonstrates substantial limitations. The conversion ratios included in these tables are merely a broad indicator of relative analgesic potency, which must be considered in tandem with other factors when switching from one opioid to another. Emphasis on limitation of drug testing, nonspecific morphine metabolites, these are underutilized. Utilizing equal analgesic doses. The calculated dose commonly understates the actual potency of the new medicine to inter-individual variation in response to opioids and the impact of incomplete cross-tolerance in the chronic treatment setting. That's the government's way of saying, be careful when you're switching because they're going to probably be more sensitive to the medication because they haven't been exposed to it yet. To reduce the risk of unintentional overdose, guidelines emphasize safety, and that's what we're doing today, is emphasizing the safety. When available, we should follow the conversion instructions in the individual ERLA package insert. That's the best way to do it. The guidelines for opioid rotation. Calculate the dose, decrease, use an automatic dose reduction window, which I think we've already done, as I've seen people flipping their pages, of 25 to 50% lower than the calculated equal analgesic dose. Select the dose reduction based on clinical judgment following an individual patient assessment. The reduction should be closer to 50% if the patient is receiving a relatively high dose of the current opioid. The reduction should be closer to 25% if the patient does not have these characteristics or is undergoing a switch to a different route of administration using the same drug. Like, so if you're going from one version of extended release morphine to a different version of extended release morphine and you're not at heroic doses, you can reduce that dose by 25%. If switching to methadone, think about that in view of the Alabama Board of Medical Examiners thought, so you may want to kind of tune this part out. But if you were to be switching to methadone, reduce your calculated equal analgesic dose by 75 to 90%. When I read this, it takes my breath away. For patients on high opioid doses, i.e. greater than 1,000 milligrams of morphine equivalents, be cautious converting to methadone greater than 100 milligrams a day. If you're giving somebody 1,000 milligrams a day, I hope you're being cautious every day. Consider inpatient monitoring, including serial EKG. And the reason for that is Methadone has an independent risk factor of people developing cardiac dysrhythmias, and there's been some people that think that the deaths from using methadone are not always from respiratory depression, but may be from cardiac dysrhythmia. If switching to transdermal fentanyl, calculate the dose conversion based on the equal analgesic dose ratios in the package insert, and in buprenorphine patch do the same. Remember that those are one-way conversions. You don't use those both ways. Following the initial conversion, prescribers should have a strategy to frequently assess the initial response, including analgesia, adverse events, and withdrawal symptoms. If you change somebody to a new medication and all of a sudden they start developing signs and symptoms of withdrawal, and we want you, if you're using opioid analgesia, we want you to be aware of the signs and symptoms of opioid withdrawal. If an immediate release opioid is used as a supplemental rescue dose for breakthrough pain during titration, calculate this at around 5 to 15% max of the total daily opioid dose, and administer this medication, this breakthrough or rescue medication, at appropriate intervals. If an oral transmucosal fentanyl formulation is used as a rescue, begin the dosing at one of the lower doses, irrespective of the baseline opioid dose. So, as I was saying, if you're going to use a transmucosal fentanyl, start with the lowest dose. And be careful doing that. Make sure that these patients are opioid tolerant before you do it. Fentanyl can have precipitous opioid side effects such as respiratory depression, so you've got to be very aware of that. This is an optional slide, and this is Algebra. Okay? And it just tells you how to compare the dose of one medication to the dose of the other. And in this particular case, what it does, it goes through the morphine equivalents as a mid-step. You know how to do that. We've talked about doing it. If something's 1.5 times as potent as morphine, then 15 milligrams of morphine is required to equal 10 milligrams of this. That's all this is. Breakthrough pain in chronic medication pain patients. Patients on stable opioids may experience breakthrough pain. Why would they do that? Disease progression or a new unrelated pain. So be aware that, you know, when I was in medical school, some of the people were cynical, and they said even crocs get sick. And that was a disrespectful way we used to think about what we need to understand is even people who have opiate abuse, who have opiate tolerance, they get sick. They may have gotten opioid tolerant or dependent because of underlying medical or orthopedic illnesses. And so they can get worse. So don't be dismissive or disrespectful to them. You always got to reassess them because they might have had something happen. It's directed at the cause. Your therapy needs to be directed at the cause of the breakthrough pain. It's non-specific symptomatic therapy to lessen the impact of the breakthrough pain. Immediate release opioid trial based on an analysis of the benefit versus the risk. You can also use non-opioids. We prefer you to use some non-opioids. Now we've done away with Peter from the previous thing, and now we've got Miss Wilma. Miss Wilma's got cancer. She's got colon cancer, and it's advanced. She has peritoneal and liver mets. She presents with increasing abdominal pain. She's waking up every night. She's already on oxycodone, immediate release 5 milligrams, Q6 hours, and 1 at bedtime. So how much is she getting? 25 milligrams a day. She has some resistance to opioids. I mean, she thinks morphine means she's about to die. She don't want methadone because that's for addicts. So, and she don't like to take a lot of pills. So Miss Wilma's might be a little demanding. So we're considering changing her to a long-acting opioid, fewer pills, and it may allow her to sleep through the night. Her current dose is 25 milligrams per day of oxycodone because, if you remember back to that table, it takes 30 milligrams of oxycodone to be considered opioid tolerant. So she is not opioid tolerant. Okay, the options for her is she can't take hydromorphone extended release or transdermal fentanyl because she is not opioid tolerant. These are only for opioid tolerant patients. This is the guidelines. She don't want morphine or methadone. So we're going to think about oxymorphone ER, and we're going to calculate her dose. She's on 25 milligrams of oxycodone, and when we transition that, we're going to reduce it by 25%. She'll be getting 9.4 milligrams of oxymorphone a day. So what we're going to do is we're going to start her with 5 milligrams twice a day. We're going to increase just a little bit more than the 25% reduction would be. So we're going to start her at oxymorphone 5 milligrams Q12 PRN. Because she is not opioid tolerant, you can't rotate her to, as we mentioned, to the dilaudid or the transdermal fentanyl. Here's the algebra once again: the value of the current opioid, the value of the new opioid, the 24-hour dose of the current, and X amount of the new opioid. And that's where, and then you reduce it by 25 to 50%. So what do they want you to do? They want us to call her tomorrow to see how she's doing. And you don't have to personally do this. If Miss Wilma's on hospice because she's got advanced, widely metastatic colon cancer, she may be on hospice. Hospice can call and report to you, but somebody needs to check in with her. But before you give it to her, you've got to warn her, and you've got to make sure that they know what to do, what to look for. If she needs more than 2 doses a day of the breakthrough medicine, then we're giving that to her as 5 milligrams immediate release oxymorphone. If she's getting side effects, we've already talked to her about constipation. She's got colon cancer, so that's something we need to be addressing when she's on narcotics in the first place. He who writes the narcotic takes care of the bowel movements. So when you start writing any narcotic, you make sure, particularly in older and debilitated patients, that you address their bowel movements with them, because that is a side effect that does not typically go away in any narcotic use. You tell Miss Wilma to store her medication securely to prevent accidental exposure or theft. Tell her that these medications that we give her could result in the death of her grandchildren, and they can be abused. Don't give any to anybody else. This is too strong a medication. Swallow it whole. Don't cut it up, because it could dump all the medicine in you, and that could be disastrous. Don't consume alcohol or use prescription or over-the-counter medications with alcohol. And take the patient counseling document to any other doctor visits. When she starts getting this, you can titrate her extended release dose. After 1 week, the pain was improved, but still moderate. She's reluctant to take the oxycodone immediate release for breakthrough pain because there's too many pills. So what we do, she has steady state plasma oxymorphone levels develop after 3 days. 3 days. Dosage may be adjusted every 3 to 7 days. So we increase her from 5 milligrams extended release to 7.5 Q12 hours with the oxycodone for emergencies. They called her the next day. Pain was much improved. She was able to sleep through the night. We will continue to watch her for development of further pain as we go along. Case summary. Her pain was not well controlled. It's keeping her from sleeping through the night. She don't like to take a lot of pills. She's not opioid tolerant, so we couldn't go to a fentanyl patch or hydromorphone. She didn't want morphine and methadone, so we calculated the transition. We put her on oxymorphone, and then that was inadequate, so we had to bump her up until we got her comfortable. And that's the way it should be with these medications. You should be able to titrate it up until you get them into some degree of comfort. Reasons for discontinuing long-acting opioids. If they're not making any progress toward their therapeutic goals, if they're not getting any pain relief, if they're not able to function better, if they're having unmanageable or intolerable side effects, if the pain level decreases as they start to heal up, if they've had some type of surgery that had prolonged pain, but it's getting to be an extended period of time after that pain, and if they're healing up, they may not need that much. Continue to reassess. This is a difficult thing to talk to patients when you say, we need to be cutting you down now, and particularly if they've had a long recovery after, say, a very complicated back surgery that had some complications and didn't do well. They're not going to want to get off this medication. So this is where it's not just the science of medicine, but it's the art of medicine to explain to the patient that we've got to have a long-term plan for you. What are we going to be doing in 5, 10, 15 years from now? You get somebody who's 30 years old, they may have 50, 60 years of life left. They don't need to be on narcotics permanently. So explain to them you're trying to protect them in the future. Non-adherence of unsafe behavior. If they bump their dose up, 1 or 2 episodes without the prescriber knowledge, and then you talk to them and say, I got a virus. Miss Wilma, for example, she got a viral gastroenteritis. Her abdomen was hurting her, or something like that, and she took an extra dose or two. Are you going to fire her from that? No, you're going to talk to her about it and say, let's make sure that you keep us in the loop. If they share medications, that's a more serious offense. So then you really got to have a talk with them and explain to them that that is not allowed. That's really against all the rules, and it may be against the law. If they're using the medication to treat another symptom, for example, somebody's got back pain and they're just not sleeping well, so they start taking an extra dose of medicine at bedtime so they can help them sleep. That's not approved. If they are having behavior that says they may be addicted or they're diverting. If you drug screen them, and do you drug screen old people that have other diseases? Yeah. Had a guy on hospice one time who later found out apparently he wasn't in pain because he was selling all the medicine that he was getting, and he was terminally ill. If they get medication from multiple prescribers, if they forge your prescription, if they have multiple episodes of prescription loss, that's just intolerable. As we've said before, if they say they lost the prescription, tell them you're gonna really suffer with them. You're gonna grieve with them over that loss. But also tell them that each one of those tablets, to think of it as a $100 bill because it's that expensive. On the street, some of these medications sell for an incredible amount of money. Okay, you may have to restructure your agreement with this patient. You may have to restructure your relationship with this patient. You may not be able to treat this patient anymore if they keep doing that with a long-acting narcotic. You can tell them, look, because of all these aberrant things that are happening, I'm not going to give you narcotics anymore, and treat them otherwise, because if they're giving it away, they're selling it, they're doing other things, they're not following your agreement that you had. When you stop it, you can't, if you're voluntarily stopping, you can't stop it all of a sudden. You'll put them into withdrawal. But now if they're getting medication from 2 or 3 other people, you can stop your part of it because they've got another source. But if you catch them overtaking the medication, doing things they shouldn't be doing, then you can say, okay, we're going to discontinue this. We're going to taper it to try to avoid withdrawal symptoms or minimize your withdrawal symptoms. We can have a short taper or a longer taper. We can recommend rehab. That's difficult in Alabama because sometimes we don't have access, and particularly if they don't have funds, having access to rehabilitation is not really easy. And we may use different approaches, as I mentioned, from a 10% dosage per week to a more rapid of 25 to 50% dosage every few days. I've seen methadone clinics do it both ways. Neither one is fun.